Good evening, all, and welcome to the Dental Council of India's Dental Education Webinar. Today, I will be the moderating 27th session in this very successful series of webinars brought to life by the dynamic executive committee members of the Dental Council of India. It is excellently managed initiative taken up by Dental Council of India in COVID times, engaging world-class speakers and top-rated faculty who are experts in their respective fields of research and clinical practice, delivering exuberant sessions on the topics of interest to our students, faculty, practitioners, and international attendees. It is on DCI's behalf that I extend my warm welcome to all of you. We would like to thank for your undue support and engagement, which has been crucial in motivating us to continue with this series. I would also like to thank the Acting President, Dr. Bharat Shetty, Secretary, Dental Council of India, members of Executive Committee, and General Body members, and dynamic team of webinar subcommittee for giving me this opportunity to coordinate today's webinar. Before we begin, I would like to take this time to run through some information which will help all attendees to make most of these sessions. Dental Council of India are free of cost. Webinars are free of cost for all attendees, and e-certificate of attendance will be conferred to all attendees, including undergraduate students, international attendees, and non-dentists on their registered emails. Certificates will be sent to attendees by email within 3 days of conclusion of the webinar, who have attended the entire session of webinar uninterrupted. This is very important that you have to, right from the login to the end of the seminar, you have to be present. Please check your junk email folder just in case of the certificate email got delivered there instead of your inbox. Attendees may also download their certificates from the webinar archives section of Dental Council of India, which is displayed here on the screen. If anyone has missed any of the Dental Council of India's previous webinar, the same can be watched on the webinar archives on Dental Council of India website. Here I would like to remind everyone to please take few minutes to fill up the feedback form. Filling this form helps us assess and improve these sessions. I would like to recognize the top 5 dental colleges with maximum participation. As you are aware of, the Dental Council of India recognizes the maximum participation of the colleges whose students, faculty participates, registers in full numbers. Their Dental Council of India recognize each one of them, all those colleges, and their live webinars with the colleges which have been got registered previously. Today we have 5 dental colleges: Savida Dental College and Hospital, Chennai; Genesis Institute of Dental Sciences and Research, Ferozpur; Vishnu Dental College, Bhimavaram; Sri Ramachandra Dental College and Hospital, Chennai; NIMS Dental College and Hospital, Jaipur. My sincere gratitude to everyone who has been a part of this webinar series. In the end, here in this today's webinar, we are going to have a dynamic speaker who will be speaking on oral habits and their implications. He is none other than Dr. Nikhil Marwah. He will be speaking in this very important topic in the practice of pediatric dentistry. As you all know, oral habits may be a part of normal development, but some of these habits can be harmful, such as digit sucking, tongue thrusting, mouth breathing. The clinician should identify these habits and guide the parents on how to stop these habits. If these habits are allowed to persist, they cause deleterious effects on the child's intraoral and extraoral features. It is important to recognize these habits and their deleterious effects to prevent gross malocclusions. The essence of today's presentation would be identification of these deleterious oral habits and their corrective measures. It is my privilege to introduce to you this dynamic speaker for today's webinar, Dr. Nikhil Marwah, who is graduated from the College of Dental Sciences, Mangalore, and completed his post-graduation in Pediatrics and Preventive Dentistry from Bapuji Dental College, Davangere. He has more than 50 national and international publications to his credit, along with more than 30 presentations at various national and international conferences and conventions. He is author of one of the most important textbooks of pediatric dentistry, which is widely read by undergraduates and postgraduate students. Besides, he has authored 4 mini books on pediatric dentistry. He is the editor-in-chief of International Journal of Clinical Pediatric Dentistry, which is a PubMed index journal. He has been associated with subject for more than 17 years and is an active member of ISPPD, Indian Society of Pediatric Pediatrics and Preventive Dentistry, and various national and international societies. He is currently the professor and head of Orthodontics and Preventive Dentistry Department of Mahatma Gandhi Dental College and Hospital, Jaipur, Rajasthan, India, and is passionately involved in exclusive pediatric dentistry practice at 4 Kids Dental Clinic, Jaipur. Over to you, Dr. Nikhil Marwah.
Very good evening to all of you, and a very good evening from Jaipur. And at the outset, first of all, let me thank the Dental Council of India, the acting president, the secretary, and the entire team of webinar committee who have bestowed upon me this honor that you have selected me for delivering this talk here on behalf of Dental Council of India. And secondly, and most importantly, I would also like to thank Dr. Pandit, who is the moderator for today. It is an honor, sir, that you are moderating this session of mine, because you are not only a revered teacher for me, but a very good friend and a very good mentor also. I hope with your blessings, I can take forward this session and give a good interactive session to all of the people involved and all of the attendees who are hearing. As sir already introduced, I am Dr. Nikhil Marwah, and I am a professor and head in Mahatma Gandhi Dental College and Hospital, which is under the Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. And this is a small picture which I always show in the beginning of my presentation. This is our department, and the reason I show this is because we are spending nearly half of our lives here, so it has become practically a part of our lives. The topic for today's presentation was oral habits in children, clinical aspects and management. When we were deciding on this topic, I thought that yes, it is a good topic which is being taught right from the undergraduate curriculum to the postgraduate curriculum. Always it has been stressed upon, the importance of this particular topic has always been shown. But in spite of that, it was very surprising to actually know that the prevalence of the deleterious oral habits is so vast amongst not only in Indian population, but also in a lot of all over the world population. If you see the Indian scenario, there are various amount of studies which give a range from 9 to maybe 34%. I have quoted some of the studies in literature over here, but there are innumerable number of studies. So habit is nothing but it is an act which becomes fixed in mind, and ultimately it is repeated out of pleasure. And it was so surprising to see that there are some international and Brazilian studies also which quote the prevalence of even 99%. So practically they are saying that every child born does have a certain amount of habit or a certain type of habit. Now, there are also go on to suggest that these habits are the most frequent cause of malocclusion. So there are important literature which shows that 35 to 50% of malocclusions are actually caused by these deleterious habits. That means it forms a very large chunk, and the negative effects of these habits will of course depend on how much time do you incidence, frequency, duration, intensity. But the whole important point we want to recognize here is these habits form an important part of our curriculum, of our management of the patient. And once we start evaluating the patient in a certain way, we will be in fact able to get hold of the habit much faster and would be able to remove that habit in a much independent way. If you look on to the classification of habits, there have been numerous which have been done over the last few years, like starting from compulsive habits to non-compulsive habits, habits which were meaningful or did have a deep-rooted psychological causes, whereas some were empty habits which were done by children just when they had nothing to do. There could be normal and abnormal habits or physiologic habits, something like which we have a natural sucking reflex is also an habit. But once that sucking reflex explodes on and then moves on to become thumb sucking or digit sucking, automatically it becomes a pathologic habit. There could be retained or cultivated habits. For example, retained habits would be those which are retained from the childhood time, whereas cultivated habits would be those which are cultivated out of some social obligations. The recent classification, or it's not so recent also, it was given in 1960s, but the classification by Morris and Bahana, which actually classifies the habits into non-pressure and pressure postural habits, looks like the most comprehensive one because it classifies each and every habit. Whatever the habit would be present in an individual, be it a non-pressure habit like mouth breathing or pressure habit like maybe biting, sucking, thumb sucking, lip biting, or some postural habit, maybe like chin rest. So various authors have classified habits according to their convenience and according to various classifications. To get into some of the habits, we will be focusing on the deleterious oral habits, and we have divided them into few sections. We would be dealing with thumb sucking, tongue thrusting, mouth breathing, nail biting, lip biting, and some self-deleterious habits also. So as we go on, thumb sucking is the most prevalent habit among individuals. It is one of the most oral habits. According to Grelin, it was nearly 45% in 3 to 4 year old and gradually decreased as the age went by. There have been various amount of studies which have classified the prevalence even up till 80%. Nanda et al. Had also classified that these are the habits which are found in most frequently in females as compared to males. Now, thumb sucking is nothing but it is placement of thumb into various depths in the oral cavity. And various theories have been postulated for this over time. You may have the Freudian theory, the theory by Sigmund Freud, who said that it could be a connection with the oral stage. If the person is not crossed the oral stage, that may probably lead to the prevalence of thumb sucking. There were other theories by learning theory by Davidson, who said that it's a learned pattern. There were oral drive theories, which probably said that it was not due to the least amount of feeding, but it was due to over amount of feeding that this habit was actually being inculcated. Then you also had Benjamin's hypothesis, which said this. You also had rooting reflex. So what they said was, in the child, whenever any object is brought near to the oral cavity, it automatically moves the mouth towards that region. So this is nothing but rooting reflex. So over a period of time, various authors have given various theories. Now, some of the common etiologies were maybe a working mother, more number of siblings, thereby decreasing the amount of attention which is paid to the child. Maybe order of the birth. because you always give more attention to the firstborn. So the second-born or the third-born child would definitely have less attention from the parent, thereby resorting to these habits. It may be due to social adjustment, maybe due to feeding practices, or even age of the child. Now, why I say age of the child is because if it is below 2 years of age or in 1 to 2 years of age, it is even considered normal because it is associated with the suckling reflex of the child. Over a period of time, there have been multiple studies which have actually tried to evaluate how much or what is the actual cause of this. And most of the studies actually say that the reason for this thumb sucking or digit sucking habit to be actually present is because of insufficient feeding in an individual, which either promotes the use of digit sucking, and it's a resort or it's a event which the individual resorts to when he is not being fed properly. Now, as I told you previously, thumb sucking is nothing but placement of thumb up to various degrees in the mouth. Now, this subtleties classification of thumb sucking beautifully explains diagrammatically what exactly happens. So if you can see, there is type A, B, C, and D. A being the most prevalent one and also the most dangerous one, because the child presses the thumb on the palate, makes the anterior-posterior contact as well as the muscular contact. So what actually happens is the entire oral musculature changes its formation. There is type B, where patient does place thumb in the same area, but there is not much of muscular force, or although there is contact in the oral cavity, but the muscular forces are limited. Now there could be type C, wherein the patient places in the mouth, but there is no maxillary mandibular contact. Automatically, the oral musculatures are comparatively better in such scenarios, and there are less chances of the habit having a more deleterious effect. And then there is type D, which is the least prevalent, wherein the child just focuses a part of the digit in the thumb, maybe just a part in the mouth, just touching the teeth. It does cause some deleterious effects, but very minimal when you compare it to the type A part. Now, if you actually see this, this is an exact posture of the thumb in the oral cavity when the child is performing the act of thumb sucking. As whenever I take a class for my students, I always tell them that habit is one chapter which you can actually remember by just performing the act and not mugging up the entire thing. So imagine yourself sucking the thumb, and automatically you will realize the changes which are happening in your oral cavity, in your maxillomandibular relation, in your thumb, in your external features. You would easily be able to guess what exactly is happening here. Now, if I would want to pictographically summarize the effects of thumb sucking, if you can see here in the top two pictures, when the child is placing the thumb in the oral cavity, it is basically breaking the maxillomandibular contact. It is also promoting the changes in the oral musculature because your buccinator muscles are over functioning to give the act of suckling. So automatically you are trying to create an open bite. So what happens is the figure number 4, if you can see, from a perfect dentition to a perfectly open bite. Now, if we want to summarize the clinical features of this particular aspect of digit sucking or thumb sucking, there would be 3 things to look into. First, any changes in the maxilla itself. So as you can see in the picture 1, it is high palate. Picture 2 is depicting proclination of teeth. Now, when we talk about maxillomandibular relationships, you have a possibility of getting an open bite or a posterior cross bites also, because your tongue musculature and your oral musculature, the forces are changed due to your placement of your thumb in the oral cavity. The most classical feature of thumb sucking, which can be seen on patients, and it's an ideal diagnostic criteria when the patient walks in the dental clinic for all the clinicians, is to identify the thumbs or the digit. Now the thumbs will be overtly clean, but they would be reddened. There would be callus formation and keratotic lesions on the thumb in case the patient is a high aggressive thumb sucking patient. Now these are our telltale signs by which we can just physically, by seeing these signs, we could actually go ahead and tell that what are the problems the child is facing. Now, if it's a birth to 2-year-old child, you could actually just counsel the parent to give more attention to the child and not worry about the act of thumb sucking, because it would be more due to the threatening of social security, and over a period of time it would change. If it's a preschool child, again, there would be an uncontrolled environmental factor here where the child is not getting due attention. So again, the most important up till 3 years of age is counseling of the parent and the child. Now beyond this, when the child goes beyond 7 years, 3 to 7 is the time you want to seriously start thinking about the reminder therapies, and beyond 7, you usually go in for the appliance therapies. So we would now focus on this together itself. So if you see the management part, so between 4 to 6 years, we have various approaches. Either we first take a chemical approach, psychological approach, or an appliance approach. We would be discussing about these approaches directly now. But the most important part here to remember is you must always prevent the patient or the parent. In fact, you should prevent the parent from nagging the child. You should never nag the child, never punish the child because of his act. You should try and counsel and try and get him over this rather than make it a punishment for him. Now, when we are discussing the various approaches in case of the psychological approaches, which are the most popular and the most effective methods of removing this particular thumb sucking and digit sucking habit, specifically in 4 to 6-year-old children. This we are talking specifically 4 to 6-year-old children. So we of course know there is Dunlop's beta hypothesis, where a child is counseled to see the act, performing the act, at how good or bad he looks, and automatically he decides to leave after some time because it doesn't remain a pleasurable act. We have something like a reverse psychological ploys, where he has to mark every time. A reverse psychology is again a very, very important tool in management of thumb sucking. Now, this is why this is important is because normally most of the times we would just counsel the patient of not doing the habit. Reverse psychology actually deals with something that you are encouraging the child to do the habit in front of a mirror, showing him how bad he looks, at the same time showing him what are the deleterious effects and how bad it can be. So that activity is no longer associated with pleasure. So once an activity is no longer associated with pleasure, the child will be actually in the process of leaving the activity because the habit is no longer pleasurable. So it is a very, very important part when you are dealing with psychological approach for 4 to 6 years old. Another very interesting approach was a book by Dragon Antelos. This was one of the first books which were there in The Little Bear Who Sucked a Thumb. Now, if you go to various sites which are there in this social media platforms, you would get innumerable such books. So these books actually encourage the child, telling him that what are the deleterious effects of thumb sucking, what are the good things which might happen if he stops the act. So it is a conscious act which you are trying to develop in a child to leave this particular habit. Now, I am sure most of you have been tried upon or have tried this particular aspect whenever we are trying to leave a habit. And it is one of the most tried habit in places which are underdeveloped because of the easy access of the materials which are available. But unfortunately, this is useful only and only if the child genuinely wants to leave the habit. Otherwise, they can go wash the hands and restart again, or maybe start in the other hand. So it totally depends on how the patient wants to go with it, or how the parent wants to approach it. However, according to my judgment, the chemical approach has very, very limited applications. Now, if the child is again 4 to 6 years old, the new approach which comes in is a thermoplastic approach, is a non-appliance approach. In a non-appliance approach, we basically are dealing with something like a reminder therapy. So this is a reminder therapy that we're dealing with. So you have your thermoplastic thumbs or your thumb guards. We have something like hand puppets. We have some special shirts which have hands stitched onto the arms. So automatically you don't suck the thumb. You have the long sleeve night suit, or you have a thumb home concept. This concept, you basically tell the child that just like you sleep in your home or your bed, the thumb also has a separate home, and you give him a bag to keep him there, so that he is encouraged not to get him out of his home and is encouraged to stop the habit. Another very interesting approach would be bandaging the arm. Now, we started with ACE bandage to begin with, but recently you have a lot of variety of bandages which can come in depending on how much degrees you want to bend your arm, and you can actually calibrate those bandages itself. Now, another very, very interesting alternatives, why I would want to mention this is because one, they are innovative ideas from our Indian dentists, and secondly, they have proven to be effective in this particular thing, in the prevention of digit sucking, where the patient wants to leave the habit but forgets that he is actually to leave it. So what it does is these appliances actually remind him. So it's a RURS appliance. It's a kind of elbow guard which has a 3-alarm system, and this was done by Shetty et al. And then there was an electronic reminder which was connected with the watch. So whenever the thumb went inside by Krishnappa et al., automatically the patient would be reminded, there would be alarm on the watch. So the patient would be reminded that I do not have to perform this habit. And of course, then somebody saw the Happy Dent ad and thought that why not to take inspiration from this Happy Dent ad and do something. And they implanted a LED device or LED diode in the palate device, which we are doing for thumb sucking. So whenever the patient went into the act of thumb sucking, his oral cavity was lit up, thereby alarming others and also alarming himself that he is not supposed to do this particular habit. So these are some of the wonderful initiatives which have been taken by our common dentists, our co-dentists from India, who have developed these various systems based on the 3-alarm system by Norton and Jelly. Now, what happens if the patient is now above 6 years and you want to manage this particular habit? Now, if you ask me, the best part is that once the patient goes beyond 6 years, your counseling has very limited effect. So you have to actually focus on the appliance therapy. Now, this appliance therapy has 2 components, the removable appliance and the fixed appliance. The removable appliance has very, very limited use because the patient always have an option to remove the appliance and keep it aside whenever they don't want to use it. So if the habit is persisting beyond 6 years of age, that means the patient is not able to control it. So you need to take control of the situation here, and you need to give fixed orthodontic appliances like palatal grips, hair rakes, bluegrass appliance, and modified bluegrass appliance. So the only difference between hair rakes and palatal grips would be more of a reminder and less of a punishment, whereas hair rakes would be punishment habits. So what happens is with all these appliances is that whenever you are inserting your thumb into the oral cavity, number one, you get a reminder that you are not supposed to do the habit. In case you still want to do it, that act of sucking would be not possible because of the presence of these intraoral appliances. And once that pleasure cycle is broken, automatically the chances of the patient leaving the habit are increased greatly. So we have to counsel the patient in such a way that along with psychological counseling, beyond 6 years, we also need to go to the appliance therapy. To summarize the entire thing of digit sucking, the onus actually lies on the patient. Most of the patients do want to leave the habit, but unfortunately they cannot due to their prefixed notions. So our duty as dentists is to counsel them and to direct them in a way wherein it is non-threatening and it is an easy way of leaving the habit so that they can go on with their normal life. The second habit, the second deleterious oral habits, which is commonly found in the individuals, is tongue thrusting habit. Now, this tongue thrusting is nothing but actually placement of tongue between the teeth. Now, it could be anterior or posterior. We would just come to that in some time. But it is just placement of tongue or the forward thrust of tongue to meet the teeth during the act of deglutition or probably during the act of speech. Now, this could be physiologic, where you have a persistence of infantile swallow. It could be habitual, that a patient secondary to the habit of a thumb sucking has developed this. It could be anatomic, that a patient is having an enlarged tongue. It could be functional, wherein it's an adaptive behavior or a gap filling tendency. Now, various classifications of tongue thrusting have been done over some time, but the one by Brewer and Townsend is the most comprehensive one because it exactly divides it into 4. So one would be non-deforming tongue thrust. Your second would be anterior tongue thrust. Third would be a lateral tongue thrust. And fourth would be a complex tongue thrust, which actually is a combination of your anterior and lateral tongue thrusts. Now, Lewis had indicated that 97% of the children born with tongue thrust, and this is actually considered normal because, as we discussed, infantile swallow is nothing wherein your tongue comes between your oral cavity or your gum pads to close the mouth. So it's a pattern of an infantile swallow. This usually decreases by 5 years of age, but around 3% of patients have seen to be retaining this habit and ultimately leading to the tongue thrust. Another classification by Moyers was basically a classification of swallows. So as I told you, we have discussed the normal infantile swallow, which we have just discussed and seen that it is nothing but placement of tongue between the gum pads. So as we already know, the maxillomandibular relation in the times of gum pads is open bite. So to prevent this open bite or to perform the act of swallow, the tongue goes there. So that's a normal infantile swallow. A mature swallow, there is a very little lip and cheek activity. It is mostly the contraction of the mandible elevators. Whereas in the simple tongue thrust, tongue will protrude into the open bite and then the patient is able to do the act of swallowing. If you consider a complex tongue thrust, in this particular thing, it would be something as a teeth apart swallow. It is mainly by the lip, facial, mentalis musculatures, but the absence of temporal muscle activity. So what it actually means is the patient is actually keeping the teeth apart and using the buccal musculature or using the oral musculature to perform the act of swallowing. That's a complex tongue thrust wherein the deleterious effects are maximum because it is most frequently accompanied with anterior and lateral tongue thrusts. Now, if you see the features of clinical tongue thrust, as we discussed before, perform the habit and you will automatically know. So once we start pushing our tongue around the teeth, we could actually evaluate what is happening. So there is a possibility of incompetent lips, a dolichocephalic or a long face. You have increased lower anterior facial height. Your tongue may also have lacerations because of continuous pressing against the teeth. Speech problems are very, very common in such patients. Speech problems are extremely common in patients with tongue thrusting because one of the oral cavity and second because of improper placement of the tongue in that region. Bimaxillary protrusion will be again common because your tongue will be trying and pressing against the oral cavity, so it will be more of a bimaxillary protrusion. Anterior open bite, and once you have anterior open bite, you automatically have a cross bite associated with it. So now, as a diagnostic criteria, if you ask me, that there are some of the examinations which are present, which may be depending on the swallow, which may be placing water and asking the patient to swallow, which may be palpatory examinations by placing the hand over the muscles of temporalis and seeing the contraction. So these are some of the diagnostic examinations which can be very routinely performed in the patients to actually diagnose whether the patient is a patient of a tongue thrust, is it a transient swallow, is it a lateral swallow or an anterior swallow. Amongst all of this, the water-based examination are the most reliable and the most comprehensive tests which are done for evaluation of tongue thrusting. Now, seeing the corrective therapy for tongue thrusting, number one would be tongue exercises, because the main idea of correction is actually telling the patient he is to keep the tongue in a particular position. That is the essence of correction of this entire habit. Now, whether it be orthodontic elastics, whether it be lemon candy exercise, whether it is 2S or 4S exercise, the whole idea is generating a correct position of tongue or making the patient realize the new placement of tongue. So you are actually removing one habit and promoting the secondary habit. So in promotion of secondary habit, automatically you realize that you are going to give a patient a newer tongue position. The most popular amongst this is orthodontic elastic exercises, where you ask the patient to place the orthodontic elastic on the tongue and then press it against the rugby area, or the 4S exercise, where you spot, salivate, squeeze the spot and then swallow. So you are, as I told you, promoting a new location for placement of your tongue, which is imperative for correcting this habit. Now, if the patient shows no particular improvement of this with the counseling which you are doing or with the regular exercises which you are prescribing for the patient, the next set of scenario which is available to all of us are the appliances or the mechanotherapy. Now, for this, we have the removal appliances, as we discussed before, and the fixed appliances. Similar to the act of tongue thrusting and thumb sucking, the removable appliances are or can be given, but their reliability, their function is limited to the great extent. So it would be much more prudent on the behalf of the clinician to actually go for something like fixed cribs or something like the new myofunctional kind of appliances, which have a much more aesthetic appeal to it, yet at the same time preventing any further malocclusions. But always remember one thing, we may be preventing the tongue from causing any more deleterious effects, but we will still not be correcting the habits. So it is much more important that we correct the habit by giving the tongue a new placement with the help of 4S and orthodontic exercises, which will be the accurate correctives of the tongue thrusting habit. Now, I took this slide from one more slideshow which I had with Dr. Gross, and it's a very interesting slide which he has. The nose is for breathing and the mouth is for eating. I am sure all of you know that the next habit which I am going to talk about is the mouth breathing habit. Now, you know that mouth breathing is actually respiration through the oral cavity or through the mouth rather than the nose. But you would be also surprised to know that the breathing in children is sometimes so correlated that they have both oral and nasal breathing. And it would be, not correct on my part if I say I cannot classify the percentages which are there, but nearly more than 50% of the children have this oronasal breathing. But the correct option for this is nasal breathing, and we must prevent any kind of purely mouth breathing. So that is the main thing which we are looking forward to. Mouth breathing, if you ask me, there are some specific factors which are located in the sense that you are to have a pathology. These are mostly associated with some kind of pathologies in the oral area or in the nasal area, oronasal area I may call it, so that it may be a trauma to the nasal cavity, it could be partial obstruction due to DNS, it could be enlarged adenoids, but this particular habit of mouth breathing is mostly associated with some kind of a pathology most of the times, because spontaneously otherwise no child would start acting or start performing the act of mouth breathing. So this is mostly associated with some kind of a oral features. So special note to all the people who are hearing, maybe clinicians, students, that whenever you are trying to treat the habit of mouth breathing, please make sure that you have a thorough examination of the oronasal cavity prior to initiating any treatment. It is a must to rule out any kind of a medical cause, a deviated septum or adenoids, which are most common in children. Now, some of the clinical features in this particular thing in mouth breathing is one, there is a classical feature. A classical feature of adenoid faces. Whenever the child comes to you, by looking at the child, you would be able to actually tell that the child is an active mouth breather by seeing his face, long expressionless face, maybe nose is tipped superiorly, adenoid, this is classical feature, this is called as adenoid faces, short upper lip, pigeon chest, and when you talk to the child would have a nasal twang in the voice. So automatically you know that this child would most probably have a mouth breathing habit. Now it is up to you to diagnose or to finally confirm the habit by seeing the dental features, maybe anterior open bites, there is increased incidence of caries, there is also increased incidence of gingivitis because the patient is keeping the mouth open for a long time. By doing this, he not only promotes the oral cavity to get dry, but also there are more chances of dental caries to develop due to this decreased salivation. Now, these pictures actually correctly depict what happens in the mouth breathing habit or the act of mouth breathing. So if you see here, during the act of mouth breathing, the tongue takes up a lower position. Now, due to the tongue taking a lower position, your buccal musculature acts on the oral cavity and starts to constrict the oral cavity. Now, this leads to marked constriction of the oral cavity as well as the common deleterious features like narrow arch, maybe cross bites, specifically posterior cross bites in this case, and deranged teeth. And sometimes we even see mandibular incisor tipping. So these are the classical features which are present in case of mouth breathers. Similarly, as I told you, each and every habit can be learned or can be seen or can be diagnosed by just observing the patient. So when we observe the patient, you have classical features of adenoid faces which are there. But these are the first findings. It is your duty to exactly confirm that actually if these habits are present, if the patient is perpetually breathing through the nose or not. And of course, now you have to ask the mouth breathers to breathe. So once they breathe, there will be no change in the nares. Automatically, when there are no change in the nares, you realize that he is using the oral cavity more to breathe. Then there is a mirror test where we have a two-surface mirror. We place it on the oral cavity, between the oral and the nasal cavity, and depending on the side of fogging, we actually know what kind of breather he is. You have Maslow's water holding test. It's a very, very diagnostic test. because you ask the patient to hold some mouthful of water. And what will happen is, if he is a predominantly oral breather or a mouth breather, he will automatically not be able to hold the water in the mouth for some time because he would want to breathe again. So this is one of the most diagnostic tests, along with Juman's butterfly test, where you have a whiff of cotton, and if the whiff goes up or down depending on that, you classify as a nasal or oral breather. Specifically, you have, if these are the tests which are conducted on hand in your dental chair, but if you want to go ahead and even do the confirmatory findings, you have your rhinometry and your cephalometric examination, which are the real diagnostic tools for identifying the habit of mouth breathing. Now, again, I would like to reiterate one point here, is that diagnosis of mouth breathing is most important because we want to find out the underlying pathology. You should not treat any case of mouth breathing without identifying underlying pathology. The main aspects of your treatment of the oral cavity here would be use of oral screen, as we are seeing here. You have various modification, the HOTS modification, or the regular oral schemes, deep breathing exercises, lip exercises, and the entire essence of treating the oral cavity is you actually use these appliances to close the oral cavity so that you start promoting the patient that he should start breathing from the nose. Now, the way to do this is quite simple. Whenever you give this oral skin appliance, make sure that it is not sealed off completely. You should make around 10 to 15 holes, which you go on sealing periodically in a week's interval, so that you shift an oral breather or a mouth breather from, and you make him into a oro-nasal breather, and then you convert him to a nasal breather completely. This, of course, is done after correction of the habit and not before correction of the habit. So it is very, very important that you realize this point. The next habit which we come to is Bruxism, and it is again one of the important critical habits in children. Now, why I say important critical is because most of the time this might be the first presentation that the parent gets the child to you, that what happens, doc, is my child has a habit of clicking his teeth at night. Now, what does the first thing come to your mind? Of course, you have various psychological factors, stresses, which are an important aspect of it, but try and understand that a 4 to 5-year-old child would have a very limited stress concentration. Of course, they can have a stress if there are, as I told, number of siblings are high, parents are not paying attention to them. These are, of course, stress-generating factors, which you will first try and identify from the parent before you go in for any kind of a dental treatment. Another important aspect of this habit is occlusal discrepancies. In case there are occlusal discrepancies, then automatically you have more chances of patient engaging in the act of bruxism. One more etiology which is not to be missed is any kind of a gastric problem like intestinal parasites. Now, in case the patient has this kind of parasitic infestation, nighttime bruxism is a very, very common habit for this. So, and in fact, it is one of the differentiating factors is the night between the nighttime and the daytime bruxism is this particular habit. So, in case of any infestation of parasites, it's going to be more nighttime. Some of the main features which can be associated with this type of habit are, of course, tooth pain, jaw pain. Patient will have a pain in temporomandibular joint area. They might even have associated headache in the ear, associated headaches, ear pains, or any kind of pain. And when you examine the oral cavity, you might actually see that the teeth are completely abraded, depending on the degree of the bruxism which happens, or depending on the time when the patient has come to you, after how much time has he been performing the act, when does the parent get to you. But the whole thing is you will see that there is gum recession, attrition, and abstraction. These are the most common effects of bruxism which are there. Now, treatment, of course, the treatment ranges from night guards to therapies, maybe proper restorative therapies by placement of stainless steel crowns and pulp therapies, or probably stress management of the patient by whichever method he wants. But the most reliable or the most doable method for this is your night guards. Now, your night guards, if you see the picture here, the top picture, recently even this type of new night guards or occlusal splints are available, which are there for a single tooth also. So automatically when you put them in the anterior region, your posterior region is not able to contact. So for such patients or for specific patients, you can think about these types of night guards also. But the most comprehensible is again delivering the night guard, but at the same time checking the underlying psychological part of the habit. The next habit is lip biting, which in fact I also have. So, or probably a lot of people have, but it is, I don't know whether they will acknowledge or not. I exactly do not have a habit of lip biting, but it's more of lip wetting. Now, lip wetting habit is one of the most prevalent habit in the entire population. It is even more prevalent than thumb sucking, but it is not reported because nobody considers this as a deleterious habit. That is why lip licking or lip wetting or pulling of the lip, until unless it becomes pulling of the lip between the teeth, you start to show some kind of a deleterious effects. You have a red and vermilion border, or you have a mentalist activity associated with it. It is not reported. So lip wetting is a habit, but not a deleterious over habit. But when you can move it to lip biting, automatically it becomes a deleterious oral habit. Now, some of the clinical features which are associated with the lip biting habit are protrusion of upper incisors. A classical feature is the presence of lip trap. As you can see in the middle picture, this is a classical feature of a lip trap. Red and vermilion borders, swollen gums, and sometimes there is even collapse of the lingual incisors with crowding. Sometimes, not a lot of times, but because the whole act is of pulling the lip from your maxillary incisors inwards, it does cause a deleterious effect to the mandibular arch also. The management of this would again comprise of an isolated lip protector, maybe an oral screen, along with lip exercises and a lip bumper. Now, lip bumper, we specifically, as I told you, oral screen is an appliance which it's a removable appliance. So you are dependent on the patient for its action. You are not very sure whether the patient would still stop the habit or not. But if you give a lip bumper, a fixed lip bumper, automatically you are ensuring that the lip is no longer able to be in contact with the maxillary teeth, thereby leaving this habit. So it totally depends on the habit, the frequency, the duration, and the features which are present to decide what type of therapy you are going to use. Another very, very prevalent habit is nail biting. Now, if you see, it is virtually absent before 3 years of age because a child, one, does not know it, second, does not have to bother about it. Then there is a sharp increase of this nail biting habit in 4 to 6 years. The reason for this sharp increase is because the child will now be entering into the school time. New types of stresses are generated, and this is the most easily gained habit. Now, if you see this, according to Malone and Kalate, this was nearly 43%. 43% of this particular habit was seen in individuals in adolescence. So why? The whole reason for this is it was initiated due to the stresses which are enforced upon the adolescent children. So in the time of adolescence, because one, they want to break free from their parents, They don't actually realize that they are children or adults. They actually turn into mini adults, not fitting into children parties and adult parties also. So that constrict over there leads them to this kind of a habit. That is why there is high incidence of nail biting with related to stress. And most of you, I'm sure, those who are watching cricket on the grounds or in your TVs are also very frequented to this habit, because we see most of the players or even spectators engaging in this habit a long time. And to name a few, our ex-India captain and the current DCI president, Mr. Saurav Ganguly, is one of the most seen people to do this. But this is just one common example which I wanted to go with no personal reference to anybody. But the whole idea is that the stresses which are generated most often leads to this habit. Now there is inflammation of nail beds, there is crowding, there is rotation, but the diagnostic feature is again on the nail bed. The diagnosis of nail bed, or when you look at the nail bed of these particular children, you automatically see that the nails are overchewed and the fingers are red. This directly implies that you are seeing a patient who is actively engaging in habit of nail biting. Now the treatments would be again chemical based or something like hand puppets, which we have already seen. And if the patient still doesn't want to leave the habit or have to leave the habit, we can then go for some kind of oral appliances, like again guards, which will prevent the thumb or the fingers entering the mouth actually to have the habit of nail biting. Now coming to one of the most important aspects of this particular deleterious oral habits is, till now whatever habits we actually saw were habits which were inculcated in the individual due to some or the other reasons, maybe stress, maybe environment. But now we are talking about some self-injurious habits, or which are also called as sadomasochistic habits. These are not gained. These are automatically inherited in the individual. They could be either due to some superimposed lesion, but most often they are seen due to some pre-existing diseases like Leishmanian disease and Deleterious syndrome. It is due to those medically compromised conditions that these particular self-mutilating habits are present in children. Now, these habits may be biting of fingers, nails, knees, maybe frenum thrusting of gingiva. They would actually pick the gingiva, maybe inserting of sharp object into the oral cavity. So these are some of the classical features which are present of these habits. And these habits, the most important corrective therapy is, of course, for these particular habits, to some extent, it may be cured by psychotherapies, or the underlying psychology or the underlying treatment to the particular disease and syndrome is much more important. For the time being, to prevent the damage, you can of course use your protective guards, your protective paddings, or start a mechanotherapy wherein the oral and the finger contact of the patient is avoided. So these are some of the aspects of sadomasochistic or self-injurious habits. Now, to summarize the entire thing, if you would want to ask me, is habit can be good or bad. It is totally on us. It is made by us. So if you want to build good habits, you have to start making it obvious. You have to start making it attractive and start making it easy and satisfying. And if you want to break a bad habit, then make it invisible, make it hard to perform, make it unsatisfactory. The minute you start doing these things, the minute you start encouraging your patients, your children to do these things, the habit pattern or the habit loop changes. Because as we discussed, as we started this slide off with first thing, habit is nothing but something which goes on in a repeated manner. So that repetition has to be broken in case you want to break a habit, or that repetition has to be started in case you wish to gain a habit. So it is totally on you whether you want to gain a habit or you want to delete a habit. But predominantly here we are talking about deleterious oral habits which we want to break. So make sure You make them invisible, you make them unattractive, and you make them unsatisfying and unsatisfactory, which will be your very basis of breaking the habit loop. Now, as my teacher had correctly summarized during my undergraduation time, they actually shared that if it's a habit, now if you hide H, a bit always remains. If you hide H and A both, the bit will still remain. If you hide H, A and B, it will still remain. So the point is, it's very, very difficult to remove the habit, but the whole target is to work on the it, so that it here basically means the underlying cause. So you have to work on the underlying cause to actually initiate this process or to finish this process of removing a particular habit. And the most important part here is to work on the underlying cause, the underlying psychology behind that habit. So if you really want to remove a habit, do not go in for just mechanotherapy. Go to the underlying aspects, make strong pillars, and then you will be able to correct it with your regular mechanotherapy. So I would want to just summarize here and say that work on the mechanotherapy, but first work on the psychological aspects of the habit also, so that you can cure the underlying problems.
Thank you, Dr. Nikhil, for such a wonderful presentation. Shall we now begin the question answer session, Dr. Nikhil?
Sure, sir.
Okay. So we should be ready with the question answer. There are so many questions, but I think because of the paucity of time, I would try to just give you some few questions, 5 or 10 questions. The first question is, what is this reason for more prevalence among the females? Reason of these deleterious oral habits among the females morely it has been seen. It is a question asked by one of the attendees.
Sir, this was a study which was done by one of the authors. I think it was Nanda et al., which they had done the study. So they have just postulated that there was more prevalence, and the reason which they gave was there is more concern or more stress when it comes to females. So females take comparatively more stress as compared to boys. That is why this particular habit, since its relation was with stress, so that is why it was more prevalent in females.
So what is the best way of breaking a habit? I mean, with your experience, such a lot of experience, what is the best way of breaking these type of habits? I mean,
sir, as I told, the best way of breaking any habit is work on the underlying psychology of it, the underlying causes. When we can identify a cause to a habit, then we can cure it. But most often where we go wrong is we start curing the habit directly by mechanotherapies without actually realizing that what is the underlying psychology to it. Maybe the child is threatened at home, maybe there are more number of siblings and the child is given less attention. So these are some of the factors which we need to look into before we actually start performing the treatment part of it. So psychological counseling, according to me, and a psychological evaluation by the dentist himself is the best particular option.
Okay. Can we do something to stop thumb sucking? In particular, there is a question asked by someone.
Mm-hmm. But that totally depends on age, sir. If we are talking about somewhere below 2 years of age or even 3 years of age, it's absolutely considered normal and you don't have to do anything about it. From 4 to 6, there were innumerable number of things as discussed previously also. We can go for psychotherapy, psychological counseling, the appliances, the non-appliance approach, wherein we have the thumb guards, the thumb homes, the reminder therapies. And if it's beyond 6 years of age, we need to go ahead with the appliance therapy.
Dr. Nikhil, there is another question. Do oral habits like tongue thrusting gets corrected during the late adolescence when an individual approaches a dentist for generalized spacing or open bite?
Yes, there is a tendency of whenever a patient is going through, specifically through ugly duckling stage or transition of teeth, tongue thrusting also occurs at that time, but this is a more of a transient tongue thrust. This transient tongue thrust can automatically get corrected once the premolars and once the canines erupt and the gap filling tendencies are reduced.
Okay. Can we get dishpan thumb as a clinical picture in thumb sucking?
Yes, dishpan thumb.
Yeah.
Dishpan thumb is a classical feature, sir. If we have to diagnose a patient of thumb sucking, the first aspect we look is in the thumb of the patient or the thumb area of the patient, because the oral area comes much later. The patient may or may not have any oral changes, but if the patient is even doing thumb sucking from last 6 months, the effect will definitely be seen on the thumb. We will have a clean thumb. It will be reddened in specific areas, and that particular feature is also called as a dishpan thumb, because once the patient places in the mouth, it will be something like this. So once the patient places the thumb in the mouth, so the position of thumb will become how it goes into the oral cavity. So a straight thumb or a normal thumb would actually be turned. So that's called that would be something of a dishpan thumb, and again it will be overtly clean because of continuously being in the oral cavity.
Okay, Dr. Nikhil, there is another question, very good question. What if all approaches fail to change the habit? What should be your take in that situation? If all situations what we are having trained at fail.
When all situation fails, sir, we must pray to God. that is one option. But as a dentist, as I said before, if you are treating the habit correctly, there is not a chance that you would not able to correct it, because habit is a learned pattern. Somebody has learned it over a period of time. All you have to do is make them unlearn. So that is what I said. In case they are just treating the habit by appliance therapy or by whatever material they are using, it would not correct the habit. They have to go to the underlying cause. The minute you treat the underlying cause, you automatically treat the habit. And I have not yet seen a patient whom we treat the underlying cause and still the habit persists. There is a limited, maybe 1 in a million chance.
Can thumb sucking affect the bone height, bone level?
Thumb sucking could lead to a high palate. That totally depends on the placement of thumb, the intensity with which the thumb is sucked, and the intensity with which the thumb is pressed into the oral cavity. So it can lead to a high palate.
Okay, Dr. Nikhil, two, three short questions I will again ask, because there is a scarcity of time now. What is the minimum age at which we can use a habit-breaking appliance for thumb sucking? Can we use it at the age of 4 years if the parents insist on using an appliance?
I would not advise it, sir. 4 to 6 years, if the patient is between 4 to 6 years, we should ideally go in for the counseling of the patient or management with non-appliances approach, like hand puppets, hand guards, reminder therapies, maybe a reminder watch, maybe a elbow guard, a bandage. These are the things which we should use before 6 years of age. If the patient is beyond 6 years, that is the time you want to go in for appliance therapy. And to answer the second part of it, if the patient is insistent, please always make sure that you are the doctor and the parent is not the doctor. So parent is going to do what you tell him to. So you have to be assertive on that point. Don't give in to the parent just because the parent wants, because you have to do what actually the case warrants.
Okay, there is another question which says that what is the management of any cases, any such type of cases in special or mentally challenged patients if they come across with this type of patients?
Sir, point one is there is a very limited scope of thumb sucking happening in these patients or special children, although there are more chances of tongue thrusting to be present or maybe mutilating habits to be present, and for such patients, the night guards or the guards where we can have a protective appliance is best possible for such handicapped patients. Because we should not go into appliance therapy, because the minute we are giving appliance to such special patients, we are automatically increasing their chances of damaging themselves with these appliances.
Okay, I think there are so many questions. I think the time may not be allowing me to ask so many questions. Okay, what is the role of an oral screen?
Sir, the role of oral screen is multiple. It depends on what habit you want to use it for. So a lot of people are also confused between the oral screen and the vestibular screen. So oral screen is when it is on the teeth itself, and the vestibular screen is when it is having the oromusculature effect to it. So we can use it during to prevent thumb sucking also. We can use it to prevent lip biting also. At the same time, we can use it for mouth breathing also. So it depends what activity you are using your oral screen for. Its function and its design will vary according to that.
Okay, there is a question from a person we all knows a lot about psychology. Can you just please explain the reverse psychology or symptom prescription again?
I think I know the person who has asked this question. Because he was the one who told me about this a few days back. So what this concept actually says is that you have to tell the patient, you are trying to retrain the patient that the act which you are doing is no longer pleasurable. In the sense, for example, a patient has a habit of thumb sucking. You tell the patient to perform the act in front of a mirror repeatedly, even when he doesn't want to. So you are trying to change the habit from a pleasure principle to a punishment principle. And the minute you go into a punishment principle, automatically it no longer becomes a pleasurable activity and the child would be dissociated. Not as good as what Sir has explained in his article, but somewhat. I would request those people who want to go into detail of this article. I had already quoted it in the beginning. You should go and read those two articles, and I think they would do a great amount of justice, because it forms the underlying basis of how to correct the psychology of a patient who's having these habits.
Okay, there is another question which is saying that, does tongue tie play any role in oral habits?
Tongue tie, sir, can play a role to a very limited extent, because if you are talking about a particular habit, say tongue thrusting, tongue tie, your tongue is already not very going to be in a position to touch the teeth, or to in a position where it can form a gap filling tendency, or it can fulfill. Neither it's going to have a major issue in case of a patient who is having a thumb sucking habit. So tongue tie can not very frequently lead to these oral habits, although tongue tie can have the deleterious effects in malocclusion.
So I will just take the last liberty of asking the last question. Any other effective modern management of mouth breathing other than old oral screen?
Unfortunately, as per my knowledge, the best method is oral screen itself. Periodic closure of holes in the oral screen, you can basically go for an improvement oral screen, and now you are having thermoplastic based oral screens rather than your conventional acrylic based oral screens. But as I said, most of these patients who are mouth breathers, we usually found that they had some kind of associated underlying pathology, maybe adenoids or the nasal septum deviation along with them. The minute you corrected it, automatically they changed to oronasal. And over a period of time, this oronasal can always be shifted from this to nasal only. But I think oral screen is the best and the most comprehensible device for this particular habit.
I think Dr. Nikhil, it was the best time if we could answer all the questions. This was a high time for all of the attendees, but due to the paucity of time, I think we should stop replying these questions. So with that, we mark the end of our question answer session. I can see that there are very few unanswered questions, but due to the shortage of time, as I have already told you, I would suggest everyone to please contact Dr. Nikhil directly via email. He has already given his email while going through this session, and I'm sure he would be happy to answer your questions. Before we conclude for today, would you like to say a few parting words, Dr. Nikhil?
Yes, sir. Foremost, I would want to thank the Acting President, Dental Council of India, the Secretary, Dental Council of India, and the entire committee members, the webinar subcommittee members, as well as the technical team, Mahenderji, Kushalji, who are executing this entire task, and a special thanks to the Deputy Secretary of Dental Council of India, who has taken special pains for keeping this webinar series going on. And a big thanks to two people specifically. One, Dr. Virendra Goyal, who is a knight in the shining armor for all of us, has guided us so much and in each and every step for this. And of course, one more person is Dr. Sivakumar. I would like to thank, because he helped me to make this presentation and provided with me a lot of information which even I did not know. So a very big thank you to all of you, and a very big namaskar and thank you to Pandit sir, you also, because it's an honor to be here with you, and it was an absolute pleasure that you were moderating my session, and I am highly blessed by this. And a big thank you to all the attendees who have taken time out from their busy schedule to attend this webinar. I hope you had some takeaway point from this particular webinar series.
Thank you, Dr. Nikhil. Here, I would once again like to recognize the 5 dental colleges with maximum participation. These are, let me take the names again: Savida Dental College and Hospital, Chennai; Genesis Institute of Dental Sciences and Research, Ferozpur; Vishnu Dental College, Bhimavaram; Shri Ramachandra Dental College and Hospital, Chennai; NIMS Dental College and Hospital, Jaipur. So, my sincere gratitude to everyone who has been part of this webinar series. I would like once again to thank our officiating President, Dr. Bharat Shetty, Secretary, Dental Council of India, members of Executive Committee, especially Dr. Chanda, my friend, the general body members, and the dynamic team of webinar subcommittee members, especially Mr. Mukherjee, Deputy Secretary, Dental Council of India, my dear friend, Dr. Virendra Goyal, who look after the dynamics and logistics of all these webinars, and subsequently made this available for us. Dental Council of India announced that Dental Council of India is preparing the next series of webinars, which will be more interactive, more innovative, and informative, and will prepare a new list of renowned national and international speakers for all attendees. We would keep you informed about our subsequent webinar series through our Dental Council of India portals and websites. We hope you all had a pleasant learning experience, and of course, connect with you soon. Thank you and have a great evening.